Yeah, so I call it serotonin toxicity instead of serotonin syndrome, or I use the term sort of interchangeably, because I think toxicity is actually a better term for it. Like it really seems to be linked with increased amounts of intrasynaptic serotonin. So it's a form of poisoning rather than it is a syndrome where there's this cluster of signs and symptoms that constitute some kind of a medical diagnosis. So when I think of serotonin toxicity or serotonin syndrome, I think that there's potentially a lot of confusion out there in the world of psychedelics because some symptoms or some responses that are just caused by psychedelics have some overlap with, I would say, less stringent kind of criterias for serotonin syndrome. So, for example, some criteria for serotonin toxicity will talk about things like nausea, vomiting, shaking, sweating, these types of things as being indicative of serotonin toxicity. Whereas, okay, they might be indicative of serotonin toxicity, but they're very non-specific. Like that could actually just be a strong ayahuasca experience and nothing pathological happening there at all. And it would just be false or erroneous to really conclude that this person's having some kind of toxicity and probably lead to a really bad trip overall if you kind of had this medical intervention in the middle of it that was unnecessary. And then on the flip side of it, there have been cases where there is some level of toxicity that is either not recognized or kind of mismanaged, or they wait too long and then the person actually tragically passes away when it was probably really a preventable type of situation or death. So really the big pieces of serotonin toxicity are seizures, like myoclonic types of seizures, hyperthermia or fevers, and change in mental status. The change in mental status might be sort of difficult in a psychedelic experience, unless it's really something like coma. And at that point, the person has a very severe kind of toxicity. So psychedelics produce this kind of somatic response sometimes. There can be shaking. There can be somatic sort of sensations. There can be nausea and vomiting sometimes, but I don't necessarily think of those things as being indicative of serotonin toxicity. I think the things that are really specific are the hyperthermia, the myoclonic seizure activity, and the change in mental status. So again, kind of like probably before comatose, you get excited and agitated and maybe kind of combative, right? So there might be sort of like, well, okay, it's definitely a non-ordinary state of consciousness, but it just seems inherently more agitated than what I would think of as a normal type of psychedelic experience. Hyperthermia and the degree of hyperthermia or fever is really useful in gauging the severity. It seems that psychedelics like psilocybin or MDMA, LSD, they do increase core body temperature, even in controlled clinical settings, by 4 to 5 tenths of a degree centigrade. So if normal body temperature is 37, 3, 4, 5 maybe. But once the fever really gets to over 38, over 38 and a half, I mean, that's 1.5 centigrade above normal body temperature. That's not a normal response to psychedelics. And that's when I would start thinking about some kind of intervention for the person. As far as the nervous system excitation, psychedelics, they can cause this kind of mild reflexia. It's usually a volitional kind of shaking where the person might actually be kind of freaked out if they haven't been told this is going to happen. It's like, I'm shaking. And it's like, well, can you stop shaking? It's like, yeah, if I really focus, but it doesn't feel good. It's like, okay, we'll keep shaking versus, a higher amplitude type of shaking where the person can't stop it or might not even seem conscious that they are shaking. That seems way closer to seizure activity than the kind of, I'll say, like mild hyperreflexia that comes along with many psychedelic experiences. Blood pressure and heart rate, they're extreme values usually if it's a serotonin toxicity, but you can kind of imagine that if a person is agitated, combative, it might be very difficult to kind of take a pulse or put a blood pressure cuff on, but those would be things that you would expect to see some pretty big changes. And then I think one other big clue is intense somatic effects that persist beyond the usual trajectory of the experience. So if you're thinking that a normal psilocybin experience is 4 to 6 hours and it's 8 or 9 hours later and the somatic symptoms are worsening, that's different. That should sort of stand out to you as like, I need to really closely watch this person and probably check in with them to see if they have some kind of fever or other types of signs and symptoms. So as far as like some equipment or kind of like training to consider, I think that the electronic blood pressure and heart rate monitor isn't a bad idea. And maybe even taking a blood pressure and heart rate like at baseline before they adjust anything. High blood pressures have been excluded from clinical trials. Hypertension is a common diagnosis, and it's also a commonly undiagnosed thing that persons just have as far as a condition goes. So, checking a blood pressure and heart rate at baseline might not be a bad idea, and having one in case of emergency is also reasonable. A wand thermometer, and you could use any kind of thermometer you want, and there's actually thermometers that are probably more accurate as far as taking a temperature than a wand thermometer. But I list a wand thermometer here because I'm kind of thinking, well, what if the person's rolling around and not following directions and not like, how are you going to take their temperature? You're like, oh, hold this under your tongue for, it's not going to work that well, right? So something you can quickly, get a gauge as far as like, do they have a fever and how severe is the fever? I think is a really good thing to sort of have on hand, because that is something that's going to be able to distinguish a toxicity from a just intense experience. Cold packs, ice. So if they do have hyperthermia, you want to cool them down. Take them to a cooler environment, put some ice packs on them, get them next to a fan or an air conditioner. You don't want to cool them down with antipyretics like ibuprofen, acetaminophen. It's not like a type of drug intervention like where you've got a cold and you have a fever and you can take one and it brings it down. Really, the best way is through cold packs and things like that. Benzodiazepines are also really useful in psychedelic emergencies. I mean, if you look at hallucinogen research guidelines for the types of struggles that persons could have that aren't amenable to emotional support, a benzodiazepine is the sort of intervention that they suggest. An IM benzodiazepine would be helpful for a seizure if it occurred. It would be helpful for serotonin toxicity if it occurred. If you had someone that for whatever reason maybe is re-experiencing a traumatic arrest that they had, and they're becoming combative and potentially threatening the safety of themselves, yourself, other participants, and IM benzodiazepine is sort of like a first-line intervention tool. And IM benzodiazepine is going to reduce the effects of the psychedelic experience itself, so it's going to ground them and bring them down a little bit faster. So if you have staff that's trained and permitted to use them, having benzodiazepines, and particularly intramuscular benzodiazepines, because if you're really having a seizure, you're not going to be able to give it by mouth and things like that is useful. I think a first aid kit, this doesn't have to do with management of serotonin toxicity so much, but you're on a property, there's some stairs, non-ordinary states of consciousness. I think you just always want to be prepared to, like, if someone cuts themselves, falls over, has a scrape or something, to be able to just kind of, dress the wound and move on. And then, I don't know, depending on who you are, your operation, things like that, CPR. If you're a therapist, you probably have some advanced training. But if you're more in the coaching spectrum, like mental health first aid, like something that can help you recognize mental health crises and respond appropriately to them, particularly if you're going to be working with populations of people that have really serious kind of mental health struggles. So it's probably some other things I could think of to like add to this, but particularly for the serotonin toxicity, I think the wand thermometer, the cold packs, and then if you're able to get the IM benzodiazepine, those would be the three sorts of things that I think could be done in the field, right? There's more things that can be done in hospital types of settings, or maybe even in transport in an ambulance. But these are things that could be done in the field to kind of get a sense of how severe is it and start some preliminary management that's going to be helpful for the person. The serotonin toxicity kind of comes in a spectrum. This chart here is something that I created. It's not necessarily from like textbooks about serotonin toxicity, But it sort of has things in bold that sort of like, well, these are the sorts of the bolded items are the kind of things where I just think like you have to do something right now. Whereas the sort of, okay, the mild zone, watchful waiting, support, cooling of fever, seems like more associated with, well, maybe that is just a strong psychedelic experience overall.